I'm Shelley Wood, the managing editor for theheart.org, and my guests here today are Dr. Georg Ertl and Dr. Subodh Verma, and our topic is valves generally. Of course, TAVI has been snatching the headlines most of the recent meetings, but we're going to try and cover some of the highlights, I suppose, in the valve arena. Starting with the German Registry, which was recently released at the ESC meeting in Munich. Our guest here today is very familiar with that data. Can you perhaps walk us through some of the highlights? What were the sort of most interesting things to an audience of people who are very much hoping to use as many of these valves as Germany has?
Well, first of all, a major advantage was that we get this registry since it's a cooperation of the surgeons, of the cardiologists, but also of the industry. And even the health insurances have now been interested in, since they see the result of this registry. The second point I would like to make is that we have a very rapid increase in Germany in such procedures, and that differs from worldwide, and is of course a problem, since these valves are put in patients who could not receive any operations by surgeons so far, if the indication is done really correctly. So it's in addition to what we have done so far, so the costs are already in addition. But fortunately, in Germany, our healthcare system takes care of these costs.
But there has been concerns that Germany was perhaps using too many of these, and that didn't necessarily bear out in some of the data.
We see in this registry that severely compromised patients get these valves, patients at very high risk, so that is a very positive result, since we always have decided that only patients who are too old and have too many accompanying diseases, comorbidities, are receiving these valves. Only these patients should receive the valves, and this appears to be in fact the case as the registry shows us.
If I remember correctly, the data does show that that you looked also at a matched control group of people treated surgically, and the results in that group were excellent, were they not?
Well,
these would have to be surgical candidates, of course.
Well, we know that in patients who are surgical candidates, the results for surgery are very good. And therefore we are in a way reluctant to expand now the indication for the TAVI to this type of patients. And the registry shows us that TAVI in general in Germany is done on very severely ill patients with heart failure, with renal failure, with stroke in their history. And of course we also see that the risk of the procedure is not zero, so we do have complications, and the complications meet about our expectations.
Dr. Verma, you're in Canada, where of course these valves have also been approved for some time, the transcatheter valves. What's your impression on their use in Canada and the choice of patient that's going for surgery versus going for a transcatheter approach?
So that's a good question. Clearly differences between Canada and Germany. I'd like to just first comment on what we've learned from Gary. I think congratulations to the collaboration between the German Heart Association and the two societies, because without having data, and this is pretty complete data, I think 90% or 95% of centers represented can only inform us as to whether we're doing the right thing, whether we're actually implanting them in the wrong patients, or whether there is a creep phenomena or not. So as you mentioned, Shelley, a few minutes ago, I think what this has told us is that despite the fact that there's enthusiasm and you're in an environment where these valves are covered and reimbursed, which is very different from the Canadian landscape, that practitioners are sort of sticking to the appropriate lines, and really not coloring too much outside the lines, if I may. that the vast majority are implanted in the appropriate patients who are at high risk, etc. But I think for the viewers, it's essential to comment that, and again, I may be a bit biased as a surgeon, but that the surgical results are absolutely fantastic, right?
Yeah.
Open surgery is a durable operation. It's been tried and tested, and in no way should technological advances in the absence of, mortality, morbidity benefits be extended to populations where we know that open valvular replacement is a clear winner. And the current guidelines that came out at ESC this year, actually a few days ago, emphasize that point yet again, that despite the excitement of and the great results, that I think it's a contraindication to be using these valves when open surgery is available.
One thing I've heard, though, to jump in here, I have heard that the advent of TAVI has made surgeons, I'm sure they've always been excellent at their work, but that some of those patients they might have said before were inoperable actually are being treated surgically now. Can you comment on that phenomenon, if indeed it's the case?
I don't think that's the case at our center. I would say, I think one of the great things at TAVI is it's brought the two specialties, which worked closely together in the past, even more closer. And I think that the concept of collaboration and interdependence and cooperation and the so-called heart team of a cardiologist and a cardiac surgeon and joint decision making has become sort of not only a mandate of institutions and guidelines, but is also it's a pleasure to see it's also something that is advocated by the manufacturers of these devices, that they want joint decision making. And I'm at our center, what I've noticed is that patients that we think are so-called borderline, where we may have, at least my own practice, may have gone ahead and done an open operation, I actually send them to the heart team for an evaluation to actually see if the heart team considers, at our center it's Dr. Mark Peterson and Dr. Bob Chisholm, whether that heart team considers them to be at a high risk enough to justify sort of TAVI being advantageous over open surgery. And it brings us back to the guidelines. The guidelines this week echo that that's a 2B indication, that if the heart team in a high-risk patient determines that TAVI would outweigh open, then that should be the recommendation.
But then, Dr. Ertl, what do you do when you have a patient who knows full well how many of these TAVI procedures are being done in Germany, who comes in saying, forget it, I don't want my chest cracked, so I don't want you digging around through my ribs, I would like the TAVI procedure, a fully percutaneous procedure. How do you handle this? Yes, the heart team should make the decision, but the patient can't necessarily
It's a very good point.
Agree
It's
with
a very good point, and I just can stress on the heart team. It's very important then that you talk to the patient together with your surgeon. And I had many of these patients today. In Germany, they just come. Why don't you do the new procedure? Are you still operating with open chest on valves? And then we take us this hour and talk to the patient and come to with the patient to the right decision.
So I've written the term heart team for years now, but are we talking about a cardiologist and a surgeon and an anesthesiologist and an echocardiographer? Are you standing around the bed of the patient, or how is the patient really hearing from both sides at the same time, or all sides?
It's in fact, in our institution, it's the cardiologist and the surgeon. I think they are crucial for the decision, and that's it. In Germany, there's no difference between invasive and non-invasive cardiologists. So in US, they differ between echocardiographer, the interventionalist, and the surgeon. But there's another point. I think it's a major advantage if surgeons and cardiologists do the procedure together, since the professions get closer and closer to this.
That's something the U.S. professional
and
society.
We do have the apical approach, which has been done, of course, by the surgeon. The chest is opened a little bit, and then by the apex, the valve is put in. So that is done by the surgeon, and then we do have the transarterial approach, which is done by the cardiologist, transfemoral, yes. That was also a result of the registry that not unexpectedly the transfemoral approach was had a much better prognosis than the transapical, but the transapical patients are more severely diseased, so they have more comorbidities, they have the problems with their vessels and have general atherosclerosis.
So Dr. Verma, is your voice being heard with patients who perhaps are suitable for both procedures? Are the surgeons getting their say?
So I do echo what you're saying. So at our institution, the surgeon and the cardiologist do the procedure together. And obviously one takes the lead if it's transapical and the other takes the lead if it's transfemoral, but they're both in the room simultaneously. So the decision making, the selection is joint, the rounds are joint, the patient is seen in a clinic that is actually where they see the surgeon or the cardiologist first, and then see the surgeon or the cardiologist next, so that they have the ability to see both specialties jointly. And then there's a joint sort of conference that then, at least in our system, we do have to, at this point, prioritize and very carefully select who will get access to this limited resource, because it is not insured. And as a result, just simply qualifying based on a certain risk score does not necessarily imply that you would get this valve. So I think it very much is following what is in the guidelines with respect to the heart team, and I'm very impressed with the German system. Quite honestly, in a system where the valve was completely reimbursed, it is very reassuring to see that practice patterns are not
appropriate.
Are relatively appropriate. Now, I did see, I think in the heart.org you covered a very nice story that some of the subgroups in the so-called lower range of the high-risk category, although they do report on most of the high-risk groups, but those who were slightly on the lower edge, did have a slightly higher rate of complications compared to those at sort of the higher risk. And I think it yet is a important sort of red flag for those individuals who are trying to, move this technology faster than it should be going. But I have to comment on what you said, Shelley, and that is, at the end of the day, you and I, all three of us, can talk about this until the cows come home, about evidence and data. But to the patient sitting in front of you in your office, they don't understand these things necessarily.
They just want
a small incision. Doctor, can I go home in 2 days? My friend had this. Can I have the same? So I think we need to find important ways to, educate our patients about who qualifies for what, and that their inability to qualify for a TAVI, if I may, does not mean that, that they're getting second-class service, and that's how many. In some
ways, actually, if they don't qualify for a TAVI, it probably means their comorbidities are such that they'll do very well with surgery.
Well said, but some people in our system feel, maybe I'm not. Maybe I'm getting the second best because the system doesn't have monies for it.
This is an important point, because we tend to think of all of the innovation being in the field of percutaneous approaches, but in fact the surgical field is advancing as well, and I'm guilty of this. I don't think we report on new surgical valves that are approved. It just somehow isn't on our radar. So we talked before the cameras started about the new, and you've referred to it, the new valve guidance here in Europe, and it has in fact made different recommendations for surgical procedures and surgical devices as well. Can you give me the highlights there?
Sure, absolutely. So just 1 minute. I think it's a pretty comprehensive document. Again, it's co-led by a surgeon and a cardiologist, and it's great to see that partnership. I think one of the highlights is the fact that the so-called sort of threshold of when people should get a tissue valve over a mechanical valve has been lowered. That bar has been lowered. And quite honestly, I think it was time to do that, because those of us who do a lot of valves have noticed that the newer generation of tissue valves, they have very good durable results, at 15, 20, 25 years with respect to structural valve deterioration. And the previous guidelines that sort of said, you know, at 65 or 70 you should get a tissue valve as opposed to, you know, a mechanical valve, were based on the first generation tissue valves that did not necessarily have that sort of durability. And patient preference and patient, you know, convenience is a very important factor. You know, subjecting someone to warfarin for a long-term sort of result, and weighing that with the rates of reoperation, or weighing that with a TAVI, you know, is something that is a new way of looking at things. You know, you put a tissue valve in a 50-year-old, and if they have to come back in the future, maybe they will have a percutaneous approach.
Dr. Ertl, that's the thing we need to wait and see, I suppose, with all these transcatheter valves, is the durability remains one of the open questions, of course.
It's clearly an open question, but I also want to follow on what you said. There has so much progress in surgical procedures. Reconstructive surgery has improved widely, and that's there always have been some institutions which have been excellent in that, but now there are many, and if today you send somebody for mitral valve reconstruction, you get him back with a reconstructed valve, and not with an artificial valve. So that has to be taken into account, and also anesthesia and all these things make operations much more safe than they have been before. So it will be a continuous process. We do many today TAVIs on patients with previous valve. So we do many valve in valve. So that's very easy, in fact, since you exactly know where to go. So,
gentlemen, I think we probably could talk about this for another 45 minutes, but perhaps we'll meet again in a couple of years and have a look back at this and see if Germany was on the right track and where the field has gone from here. But thank you both for talking about it with me today. Thank you.
Thank you, Shelley.
Thanks very much.